everyone, welcome to researchmd.com. Another great presentation today. Today we're going to teach you everything about frozen shoulder syndrome under 9 minutes, the facts, very precise manner. So that's why we want everything that should be done under 9 minutes. Make sure you're repeatedly watching so you can remember. There's no pointing. I always tell watching like an hour-long video, you don't have time to review it. Very important to watch our presentation, short review with all the significant information you need. Again, my name is Pramil. Cheriyath. I'm a program director in internal medicine, transitional residency, assistant professor of medicine, 2 major medical schools, and I also teach medical students and residents on a regular basis. I'm a director of research also. So let's look into the definition. What is frozen syndrome? It's a very, we know it's like a very painful condition. You can also call it as like adhesive capsulitis, okay? Pain and significant loss of both active range of motion and passive range of motion on the shoulder. So you got a nice picture over here, normal shoulder, and then you got the frozen shoulder. So what happens is like adhesive capsulitis, a very painful condition, so we'll come back to it. So epidemiology usually affect patient age greater than 40 years, incidence 40 to 60 years, more common again in women. But remember, if a patient comes with the diabetes with a shoulder pain, always kind of think about could be frozen shoulder. And you got around 2 to 5% of the general population, 5 to 11% if you have shoulder surgery, 10% of the patient following surgery for breast cancer also. Again, diabetes is a big thing. Etiology, I mean, you usually have like fibrosis, contracture of the formation of adhesion around the glenohumeral joint, okay? It can occur spontaneously, or it could be like secondary to, shoulder trauma, which we talk about, surgery and all those kind of things. So again, the risk factors, we know female sex, age greater than 40, shoulder trauma, surgery, diabetes, always remember diabetes, autoimmune disease, deep uterine contracture, and even the breast cancer. So let's look at the pathogenesis of frozen shoulder, okay? You got elevated concentration of inflammatory cytokines, B lymphocyte, T lymphocyte, macrophages. They're found in the capsular and bursa tissue. There's decreased level of matrix of metalloproteinase and elevated concentration of tissue inhibitor of metalloproteinase. It lead to imbalance between the extracellular matrix, tissue degradation, remodeling, and regeneration, okay? Then you have the fibroblasts mixing with the type 1 and type 3 collagen and transform into smooth muscle myofibroblasts. So it forms like a thick band of collagen. That's what causing the contracture, hyperplasia, and eventual fibrosis. What happens when you have fibrosis? It reduces the capsular volume, causes stiffness, leading to a restricted movement of the active and passive, okay? The patient usually go through 3 stages. You got stage 1, stage 2, stage 3. Stage 1 is called freezing stage. The other one is called frozen stage, and you got a thawing stage, okay? First 3 months. So what is the freezing stage? You got severe inflammation of the shoulder joint, inflicting extreme shoulder pain. And then after like around 3 to 9 months, you got to have the start to decrease, stiffness still there, difficulties during daily activities, maybe up to stage 3, 12 to 24 months, pain and stiffness of the shoulder, and overall symptoms gradually subsides, okay? So a long process. So there's 2 types. One is the primary, idiopathic. Nobody knows why is it happening. Secondary develops to underlying disease process like, systemic, intrinsic, and extrinsic, which you're going to talk about, okay? So when you got secondary frozen shoulder, there's like maybe systemic connective disease process, diabetes, hypothyroidism or hyperthyroidism, hyperadrenalism. And then you can also that is the systemic causes. What are the extrinsic causes? You got like cardiopulmonary diseases like CVA, cervical disc pathology, humeral fracture, and Parkinson. Then you got intrinsic, so it's from known shoulder pathology, including not limited to rotator cuff, like arthropathy, and so most of them those are the intrinsic causes, like any kind of shoulder pathology associated with it. On examination, you ask the patient, you assess the payment when you examine the verbal on the scale and observe willingness to ability to use the affected, upper extremity, either edema, resting position of the upper extremity, all of this you should, and the postural assessment, cervical, thoracic, lumbar alignment, and humeral scapular position, and typical finding may include forward head position, protracted scapula, and excessive thoracic kyphosis, okay? So first thing you have to do an examination of the palpation, your tenderness to palpation in the bicipital groove at the point where the joint capsule bridges the gap between the greater and lesser tuberosities of the humerus. It's not always present unless there is an anterior capsule is stretched, okay? Then you got upper quarter neuro screen, that is reflexes, myotomes, and dermatomes. Range of motion, we talk about the active range of motion and the passive range of motion, and they got muscle performance strength, the manual muscle testing of the handheld dynamometry testing, and diagnosis, joint integrity and mobility compared to the contralateral side. 30 to 60% loss of joint mobility is expected, and there's some special tests we can do. We're going to talk about it to look at the diagnosis, okay? So the first one I want you to talk about, like the NEER impingement test, okay? You got a good, sensitivity is around 72% and specificity of 60%. So how do you do NEER impingement? First, you clinicians stand behind the patient. First, you stabilize the scapula. Go behind the patient, stabilize the scapula, okay? And the patient elevate the arm into full flexion with a slightly internal rotation and forearm pronation. If the test is positive, the pain occurs lasts at least like 10 to 15 degrees of full glenohumeral flexion. Then if there's a pain, that's positive, okay? So the positive test suggests that impingement of rotator cuff tendon right there. And then you got the Hawkins impingement test. Again, the sensitivity is like a little bit less, like 79 and 59% respectively. First, you seat the patient, and the elbow is flexed at 90 degrees, and then the shoulder flexed forward around 90 degrees, and the clinician maximally internally rotate shoulder while stabilizing the scapula. What is the positive test? It's say like, source of impingement is compression of the rotator cuff. You're going to have pain when you do that. So imaging, not necessary, but you're doing it to make sure, like, all the other causes are, like, you're ruling out, like, most of the other causes. Like, most of these things, you do those tests and examination, you should get the diagnosis. Rare cases, you can do maybe MRI, X-ray, arthrography, and you can do an ultrasound. So the treatment, you can do like a lot of exercise, one range of motion exercise, like pendulum exercise, passive range of motion, and active range of motion is very important, okay? Then you have transcutaneous electrical nerve stimulation. You got strengthening exercise with the pain-free range, joint mobilization, and then moist sheet. Also, you should try stretching, muscle re-education to regain normal, and the scapulothoracic biomechanics to improve. Okay, so contraindication or precaution for treatment. Contraindication, if there is a joint hypermobility, you should not do it. Precautions when you have patient have malignancy, bone disease, unhealed fracture, excessive pain, hypermobility, total joint replacement, systemic connective tissue disease, and joint diffusion inflammation, and the elderly individual with a weakened connective tissue would be like a or precautions we can say for the treatment. Prognosis, most of them self-limiting. We already got about the stage 1, 2, 3. You should be able to, it's a long protracted case, like you can have to go up to 1 to 3 years, 20% to 50% develop symptoms for 3 years, 6 to 17%. Unaffected shoulder may also can develop adhesive capsulitis. These are the references. Thank you so much for watching. We'll be back with another presentation soon. Please subscribe to our channel.